All right, we will go ahead and get started. Hi, everyone, and welcome to the Patient ID Now Coalition's webinar, The Match It Act, Charting a Path to Accurate Patient Matching. I'm Kate McFadgen, Senior Director of Government Affairs at the American Health Information Management Association. We're excited to share with you today information on patient matching, as well as the Match It Act introduced in Congress. We will have time at the end for questions, but during the webinar, please feel free to put any questions you might have into the Q&A box. Today's webinar will be in two sections, a panel discussion around what's happening with patient matching on the ground, and a history of the patient matching issue in government and how you can engage. For the second portion of the webinar, I'll be joined by representatives of two of the other founding organization members of the Patient ID Now Coalition, Cassie Ballard, Director of Congressional Affairs at CHIME, and David Gray, Director of Government Relations and Connected Health Policy at HIMSS. First, though, I'd like to go to our panel discussion and introduce our panelists. Today, we have Sean Kelly, Chief Medical Officer and Senior Vice President of Customer Strategy of Healthcare at Imprivata, Grant Lansbach, System Director, Health Information Management at Intermountain Health, and Rachel Podservinsky, Executive Vice President of Harris Data Integrity Solutions. Thank you all for joining us today. So first, I want to turn to our panelists and just sort of laying the groundwork. What does it mean when we say patient matching? And what does that work look like from your perspective? What challenges are healthcare professionals experiencing today when it comes to patient matching? So Rachel, let's start with you.
Sure. Thanks, Kate. Thanks, everyone, for having me today. It's great to be here with you all this afternoon. Patient matching is such a challenging issue and something that is certainly not new to us in our healthcare organizations, but something that has been complicated significantly by interoperability, the sharing of data, large healthcare systems, and integrated delivery networks. So the bigger the data gets, the more this challenge persists. I think we talk a lot about what those errors are that occur in the patient matching sphere. So we're talking about duplicate records where there's two records assigned to one patient within a health system. We're talking about overlaid records where there's one record that has clinical information from more than one patient. So those patients can be treated incorrectly. We're talking about crossover records that are actually two records that are assigned at different health systems, but now they're connected at an enterprise level. So really kind of understanding the difference of those errors and how those impact the patient and the health system. So when we talk about those errors, they occur in the electronic master patient index. That's the backbone of your entire health system. So everything you're doing within that is based on that data and that information that's entered in kind of on the front end when patients are registering and when those errors occur. So any challenges that you have in patient matching within your system is going to have an impact on patient care. It's going to have an impact on your financial systems on the back end, on just how efficiently your system runs, and certainly on any AI implementations that you happen to be working on is something to be super concerned about as well. So, and a lot of these hurdles are, we enter that data demographic. Sometimes the patients are entering their own information now. So where the data is coming from and what that source of truth is continues to change as well. So there's a lot of challenges there.
Absolutely. Dr. Kelly. And Dr. Kelly, I don't think we can hear you.
How about now? Can you hear me now?
Great.
Eureka, technology. So thank you, Kate. And in addition to being an Imprivata, the Chief Medical Officer, I'm also a practicing ER doctor. And so I'd like to echo a lot of the points that Rachel said. I think it's really important to spend a little bit of time on the problem because, oftentimes we think, well, how hard can it be, right, to match someone to their data? And it turns out actually it can be really hard, right? Human beings make errors of roughly 10% of the time anyhow, just unintentionally trying to fat finger in data. When you add into that things like, I just want to put you into the real world of medicine. When you show up at my ER, you might be a patient who is hard of hearing. You might have language barrier issues. Culturally, you may list your date of birth, totally in a different convention. You may not know your date of birth. You may have altered mental status. I mean, we have trauma patients come in all the time and create these quotes, trauma charts. that we have to merge later, obviously that is ripe with issues too. And so, you know, patient matching isn't just matching the human being in front of you to one data set. As Rachel said, it's matching it to all the data sets out there. And as you know, interoperability between Grant's hospital and my hospital and other hospital depends on so many different things, governance and policy, in addition to technical and operative interoperability and standards. So there are many failure points. There are many reasons why this can go wrong, but it's incredibly important to get right. And so I'll let Grant speak to it too, but I just wanted to give a little bit of the real life color on, you know, when someone presents, actually it can be really hard to get the data correct. And as Rachel said, we'll talk more later about the downstream effects of all of these misidentifications and the bad data. But I want to just say, I guess one other thing first, again, putting my doctor hat on, you know, medical error is still the third biggest killer of Americans today, behind only heart disease and cancer. You know, 250,000 people per year at least die that we know about from medical error. And while not all of that medical error is attributable to patient identification issues, it's certainly a very large and correctable and preventable percentage of that error that leads to harm and adverse events. And that's not even to mention all of the potential errors and near misses that we have, which again, Grant and others that deal with this every day understand that Swiss cheese and how often that we actually have near misses too. So Grant, I'm sure you have more to add.
Oh, yeah. Thank you all very much. Yeah. So I would just focus a little bit on some of the actual challenges that we see that I think are sort of trends. One of them is that we are using discrete data fields mostly to match patients, right? We're not using a single number, which is what this is all about, to be able to match who's who. And that is a big cost to a lot of organizations because we're employing third-party vendors to help us figure out if it's the same person. So there's that cost. People are using social security number less and less. They don't have to give that, and they're not. So we are getting less and less social security numbers, which is one of our best fields to try and match on. Patients are in the record a lot more. They have patient portals and they can go in and create visits themselves for like video visits or different things like that. So they're now in the mix, being able to create themselves in our data, which is not always done correctly, that kind of thing. And then we're also doing a lot of matching and loading in a lot of patients for payer reasons. So they're not necessarily even patients of ours, but we're loading them in because we may be tracking them for accountable care organization types of purposes and things like that. So we're loading those patients in and trying to keep track of all of them as well, even if they're not direct patients of ours. So the databases keep getting bigger and they keep getting a bit muddier, if you will. So those are some of the biggest challenges that I see on the horizon right now that we're dealing with.
Absolutely. And that's such a great way to sort of lay the ground of where we are. And so I want to turn a little bit, you know, as you all have mentioned, the consequences are when patient records aren't matched correctly, we do experience patient misidentification. So what are the different ways that patient misidentification occurs? Rachel, I think you started to touch on this a little bit, but and why is patient misidentification such a problem for hospitals, health systems, interoperability? So Dr. Kelly, let's start with you this time.
Sure. Again, I think I'll take us back to the caregiving scenario, and you can imagine the complexity of many patients coming into our care environment in the ER. You know, if you come in, you have allergies to medicines or you don't, you might be on medicines or you don't, you have underlying conditions. Simply knowing that you're on an anticoagulant, like a blood thinner, markedly increases your risk that your source of altered mental status might be something like a head bleed and we need a CT scan. But if I don't have your records, I might not realize that, and I might not think along those lines, or I might treat you with a medication or perform a test that you actually have an anaphylactic or severe allergic life-threatening reaction to. So in order to properly diagnose, you need to know as much data about the patient as you can. And in order to properly treat that proper diagnosis, that even depends on it, right? And so the farther downstream you go, as soon as you feed even one small error into that equation, it can lead to numerous problems downstream. I like to think of it at least in three categories, right? There's patient safety and quality of care issues. There are financial issues, and then there are experience issues, right? Workflow and, time taken and patient satisfaction issues. And, I could go on all day about this. I'd love to maybe have a round robin discussion, and I'm happy to continue on this topic because I think it's so important to understand the issues and the problem before we talk about potential solutions. And, shining a light on that problem and understanding all the different components of the workflow and the fact that there are people issues, process issues, and technology issues in play. And there are actually solutions in those areas too. So I'll pause. I don't want to go on too long. I'll pause and let the other panelists jump in, but this is a really important conversation.
Grant, let's go to you.
Yeah, I mean, wow, that was really good. You summed it up very well. I think that just the nature of the electronic health records being dynamic is very scary. Like doctor was talking about, if you have a medication administration record, right, you have your medications in there and then you don't have the right person, those carry over from visit to visit to visit. Those are at the patient level. So whenever something's wrong in there, you could definitely be doing something medication wise to a patient that is not that patient. It could be very scary. So from a patient safety perspective, that's huge. But I also wanted to say too, in other areas besides overlays or misidentifications, duplicates are bad like this too, because if you have multiple records for the same patient and they're showing up at different places and not being put together, then doctors are, they're retesting, they're doing a lot of the same tests. There's a lot of waste in the system and frustration for the patient as well, because they know they already had that test 2 or 3 weeks ago, but they're not put together, so the doctor can't see that. So, that's the other side of that coin too. When you have too many of the same patient in data, it causes issues too. So I wanted to kind of tag on to that as well.
Rachel?
And I guess I can talk a little bit more about how kind of the functionality of how these errors get into the system. I mean, generally, there's a lot of ways, but if you think about, most of our patients are coming in through registration and patient access. That's a very high volume department area of people that are in a hurry to get people into into their hospital and to where they need to be. There's also a lot of places that still have decentralized registration. So there might be multiple areas within your healthcare systems where data is being inputted into your electronic health record. And those staffs tend to have they tend to have a high turnover rate. So it's an entry point for a lot of hospitals where there's, this is where people kind of get in. And then a lot of times they move on to other places within the facility. And I'm not sure what last time I checked, I think the average timeline of a patient access person was 8 months or less. So if you think about this is an area of constant turnover and constant training. And it's really important to make sure you train those people to understand the implications of what they're doing in the system, not just you're entering these people. It's if you do this wrong, here's the consequences that might occur. So I think a lot of it comes through that area, but there's also interface errors. So there's sometimes you don't even realize that all of these duplicates are being created until the next morning you come in and your queue went through the roof and now you've got several thousand duplicates to work. So some of it can come in that way. Grant talked a little bit earlier about additional data coming into your system. So there's a lot of mergers and acquisitions right now. There's a lot of Community Connect sharing and the ACO information and kind of that stuff coming in. So as more data gets added into the EMPIs all the time, those errors are being created just because of the growth in the system and those records coming in. And so you have to have, there are technology tools that help with that, but then in addition, somebody needs to work the ones that aren't super obvious. And we know that that's obviously a constraint for financially for employing people, having enough, basically folks in your departments that work duplicates on a daily basis, because in order to keep up with it, you really have to do that. And we know that those places are challenging as well.
And Kate, maybe I'll just finish with another anecdote because I think it does help. We get these big issues, but you think about one person and one patient, it kind of just helps solidify it. So we had a patient come in, she's like a 50-year-old female, had leg pain and swelling, and we were worried about a blood clot. And it ended up that for whatever one of the reasons that Rachel talked about, we had a duplicate chart. So her chart in front of us that now have all the data that was in it from prior visits from an affiliated hospital, not our hospital, but an affiliated one, which normally we could see data from. And, you know, she was not English speaking. She was a bit upset, and we did a bunch of tests and appropriately found she had a blood clot in her leg, a DVT, deep venous thrombosis. So the treatment for that is anticoagulants, a blood thinner that we talked about earlier. A lot of risk with that, a lot of benefit. It's a high stakes game that we're playing, and you want to do the right thing. Well, lo and behold, Grant had talked about the fact that patients are able to access their own records. We figured out that she showed me her record on her phone, and she actually had an ultrasound 2 months ago, and I was able to see the report and then find out where it was, identify that we had a duplicate record, get into her real record and compare the reports side by side. The blood clot was actually improved. So she did not need anticoagulants. And it was only by seeing the right data that we're able to make that assumption. If not, she would have gone out the door with an anticoagulant on board that she didn't need, which of course is a high risk. So again, you know, we cringe, but these kind of things actually, especially as the population ages, our medical care is getting better and more complex. Most patients that come into our treatment areas have multiple comorbidities, they're on multiple medications. And so it's a complex world. So again, getting the data right upstream as much as possible means that downstream, you're not getting the wrong diagnosis. There's malpractice risk, there's liability risk, there's brand and reputational risk to the hospital. There's personal, very direct and personal risks for safety issues to patients, to their providers. There's frustrations, there's workflow issues. And, you know, at the very front end, as Rachel said, patients don't necessarily want to walk up in a busy area and give out personal information in this era of getting hacked by everybody and socially engineered. So even the very root issue of verbally giving several points of data, which then can be searched in the software, is flawed to begin with. So we'll get towards some of the solutions in a minute, but those are just some of the implications of the very real problems.
Absolutely. And that's such a great segue into our next question. And we really want to talk about the patient experience. So we know that the consequences that patients experience from misidentification can be really dire. So can you all talk a little bit about what issues does this cause for patients? You know, what are the downstream effects post-clinical encounter even? So Grant, let's start with you this time.
Yeah, well, certainly a lot of the things we already talked about from the clinical perspective, but also the billing is big. If they get, you know, incorrect bills and things like that, it can be very frustrating. Or you're a patient who hasn't even been into that facility for a number of years and you get a bill. You start wondering, why did I get this bill? I haven't even been there, right? I mean, that's horrible. And that's a PHI violation too. So in those cases, organizations have to respond accordingly because they are PHI violations that happen. I think I was thinking about this. I think I'd flip the script a little bit and tell you this about patients that's interesting, is that I think most of them kind of assume that you will know who they are somehow. And I am always like, how would you think we would know that, right? Like if you haven't given us, especially a social security number, and you haven't been here in 5 years, then the data that we have on you is 5 years old. So if you're like a female that has been married or divorced since then, and you've changed your address and everything, you know, I think that they actually think in this day of technology that there is this ID out there or something that links them together. And they're always shocked. Why don't you know who I am? You know, and we're like, oh my gosh, you really don't have an idea that this is very archaic, the way that we do this. We do this off of your demographics. And we're looking at demographics that could be over 5 years old to try and match you. And so I think that's interesting because as we talk about this initiative today, what's funny about it is a lot of patients already kind of think it's happening or that it's going to happen somehow without really understanding what's going on behind, and unfortunately not really understanding kind of how archaic our methods are to do that.
Mhm.
And Rachel, how about your perspective?
Yeah, I think it can be super jarring as a patient to see results that aren't yours, I think for sure, you know, and we see this story all the time. You know, somebody has a diagnosis or a medication or something in their record. Now we have patient portals, so we're all getting that information right away. So you go have a test. A lot of times you're getting the result of your test before your doctor even, or at the same time that your doctor's getting it. So that that time that, maybe we had an opportunity to correct something in the past is gone. So you're instantly getting that feedback. So getting a test result or something that isn't yours, that maybe has something, scary, or being the person on the other side that did not receive that test result. There are several stories on the Patient ID Now website that I would absolutely recommend everyone to go look at. Like there's one out there of a lady who got results from a mammogram that she, had cancer. Well, it was the wrong results. So she thought she had cancer. The person that actually did had delayed care for, I think, a year before they figured out the issue, that they had given it to the wrong person. So, you think about those situations. That's absolutely devastating for a patient to experience that. But even you might see something and think, oh, it's no big deal. There's this weird thing. I don't think I had that. I actually saw a video on social media of a lady that just got out of her visit and was like, they asked me about this address I never lived at. And then they thought that I was on this, antidepressant medication I've never taken. And then I responded right away, like, they overlaid your record. You need to call them back and, make sure that you get it fixed. Because I think Grant's right. People don't understand necessarily what happens on the background and what kind of errors we can make in the healthcare system, because it would be great if everything was perfect. I talk about this a lot, that people don't understand why we make errors in the healthcare system when obviously the financial system gets it right and there's all the other places that can do it. And I'm like, well, we have to treat patients no matter what information they give us. So whether or not it's correct, whether or not we have an identification, whether or not they can even tell us who we are, we still have to treat them. So we have a lot more challenges than other institutions.
Yeah, it's true. By law and ethically and morally, of course, we have to treat them and want to treat them, but it's not unreasonable for them to expect us to do better, right? Other industries do this. I flew to Europe last week and I did my identity verification with my passport document with facial matching. And then I got on the plane with facial matching, and I did get a human check of those things at one point, but not when I got on the plane. It literally did facial recognition with liveness detection, and on the plane we went. And so, whether it's universal patient ID number or better matching technology, the referential matching and AI behind it, or, at Imprivata, we're doing facial biometrics and other places do that. I think there potentially are solutions out there in the world that we in healthcare could leverage to start trying to fix this. I know we're going to talk through that, but I think we should demand more of ourselves, and the patients are right to do so.
Absolutely. And I know that since I have started working on this issue as a patient, I always check my record, double check it now. Just hearing all of the stories out there, I think one of the stories, as Rachel was mentioning, that the Patient ID Now Coalition shares often, is that there was a healthcare system in Texas with thousands of Maria Garcias, and hundreds of those share the same birth dates. So even with the best efforts, it's very hard to parse through those different patients.
Unless you use technology that's unique to that one person, such as
Exactly.
a biometric, may be triangulated with other things, like something someone knows at different points. So there are solutions that are readily available. I think, as a healthcare industry, we just have to push towards how we should adopt them, if we should adopt them, guidelines around it, the governance to make sure that it's properly cared for. Everything in medicine is about risk versus benefit, and the risks of misidentification are so large, the benefits are so great, that we have to consider all of our tools, whether that's universal patient ID number, whether it's better matching software, whether it's other things, in light of that, I would think.
Absolutely. So for our final question to our panelists, I want to ask, what happens to patients in the healthcare ecosystem at large if we don't address this issue of patient misidentification? So Rachel, let's start with you.
Sure. Well, I think this is a problem that if we don't address it, and we haven't addressed it well in the past, it will just continue to grow. The problem will continue to get bigger because the health systems are getting larger. The data is being shared across larger areas. We have huge health information exchanges now in the QHINs and everything. So we really need to think about how those small problems at your single health facility are replicated in these larger data sets across the country, basically. So it's just going to keep growing. I think that one of the big things that, in addition, that, you know, we're all struggling with staffing in our hospitals and having enough people to do this work. And, you know, things are going to get, I mean, we've got a lot of new things passed that looks like it might get a little bit scarier for us on the ground floor, really, with how many people you have working for you and if you can afford to put FTEs to this. And it's one of those problems that if we don't solve it, it's going to keep costing us more money. I think, you know, there was a study by the Ponemon Institute that the average healthcare facility spends $17.4 million a year on denied claims and lost revenue. 35% of that is due to patient matching issues. So, I mean, just being able to fix, and that's, I think that equates to like $6 billion annually. As a country, we're spending $6 billion on this one piece of our healthcare. That doesn't have anything to do with patient care, right? This is really just on the back end on how we're managing things. So if you think about just fixing that one thing, how much money that would be able to save just in that space, you know? So it's just gonna, and that, like I said, it'll just keep growing if we don't find a better way. I really like Dr. Kelly's idea to like, how do we continue to fix this? I do think that facial recognition is something that we're all getting so used to. Like we talked about it at the airport. We're doing it on our phones all the time. It's something that people are getting more comfortable with. So I do see that being a potential solution, hopefully that people will kind of adopt some of that stuff. But also, you know, if we could get AI to do some, you know, like Grant said earlier in the thing, a lot of our matching is based on patient demographics and that high level information. You know, if AI could mine the clinical record and look for more information in there to really help us match some of that other data up, which is very difficult to match right now, you know, we might be able to start coming to some solutions. But I think in general, without that, you know, without those, without a new solution and embracing technology while still being able to have our people, because patient matching isn't something that can be 100% solved by technology. It's just not, I don't think it's going to be a while before we get there. Without that, it's just going to continue to be exasperated.
Mhm.
Dr. Kelly.
Yeah, I mean, as Rachel said, I think that the financial costs are exorbitant, right? And in addition to denied claims, even trying to get clawbacks from payers costs money for hospitals, accounts receivable goes up. So it's expensive for hospitals, it's expensive for the government, it's expensive for payers. And the little bit of error in the beginning gets amplified downstream. You know, people get unnecessary tests, and we talked about the fact that's unnecessary risk for them, and they may get IV contrast dye or radiation that they don't need, or even an infusion they don't need, and that's medical risk, but it's also financial risk because payers don't want to pay that. If they do pay it or the hospital ends up not getting paid back, it's either bad debt or it goes into the kitty for more unreimbursed care that inflates everybody's copays the next year. So it's this never-ending cycle from a financial standpoint. The credibility, brand, and trust issues against hospitals, not to mention malpractice. Those numbers we'll probably never understand because, of course, hospitals don't want to be talking publicly about some of those misses. Sometimes they do and they're transparent, but whatever we know about is the tip of the iceberg. And so preventing even 10 of those major events per year across the US would save millions and millions of dollars, not to mention life and limb. And so there's just so many downstream issues. And then there is this issue that Grant brought up, like, you know, Meta and all these other companies know more about us due to our data, and yet in healthcare, we're backwards. So I would argue we should know more because it's more important for us to know if Grant's at risk of a heart attack or a stroke or anything like that. Like, so if we can identify people, clean that data, and let AI and our own systems do better, then we can actually save lives. So there's not just the cost, but there's the opportunity costs of what we could do with accurate data. Like if this is how well we can do with really bad data, imagine what we could do, the power of good data. So I guess it's multifaceted, of course.
Grant.
Yeah, I would just finish with an analogy that I did at another panel with the Office of National Coordinator a little while ago, where we were being compared in healthcare to the financial industry and saying, you know, how come they can keep people's identities straight and you guys can't? And I said, okay, let's flip this around and do a quick analogy. Let's say I walk into a bank with $30,000 cash and I hand that to the teller and I say, now I'm not going to tell you my real name, and I'm certainly not going to give you a social security number. And I'm going to go ahead and have you deposit this $30,000. Then I'm going to show up sometime 5 to 10 years later from now, and I'm going to expect that money back. They're going to show you the door. They're not going to take your money, right? Because there's no way that they could find out who you were 5 or 10 years from now. They wouldn't want the risk. But that's exactly what we do in healthcare. And that's where I think the the idea of a national patient identifier, something like that. The other analogy I would use on that is I would say, okay, so what's worse to lose, a check or a debit card? Okay, and the answer is the debit card, right? Because the debit card references the checking account and routing number. And so a national healthcare identifier would be much like that to your social security number, right? So that if that was compromised at some point, at least it would be limited to your healthcare life. It wouldn't bleed over into your educational life, your financial life, all of that. So that's where I see that as being a very tangible solution at some point for us to be able to keep track of who's who without having to use the social security number, which is, part of so many facets of our life, and being able to have an identifier that's unique to our healthcare life. I think that would go a long way, and I think that would get us closer to the kind of outcomes that we always get compared to in other industries, like the financial industry. So.
Absolutely. Well, thank you so much to our panel for providing your on-the-ground experiences for what patient matching looks like in the field. I see we've got a lot of questions coming in the Q&A, so we will ask those questions of the panel once we get towards the end of our webinar. But first, I'd like to turn to David Gray of HIMSS, who is going to start to explain some of the history of how we got here. So we'll pull up the slides and have David sort of start giving us that history.
Hey,
Thanks,
Kate,
Kate.
you've disabled screen share.
Apologies. I think you should be able to now.
Thanks. All right, is everyone able to see that well?
Yep. And
Excellent.
can you hear me? Okay. Wonderful. All right, next slide, please. So how did we get here? The oversimplified answer, and sorry, I'm David Gray, Director of Government Relations and Connected Health Policy with HIMSS, one of the founding members of the Patient ID Now Coalition. So the oversimplified, at least policy answer to how did we get here is that we still don't have a national strategy to address patient identification and matching. As you heard in the previous panel, there are various tools and solutions that are being very successfully deployed throughout healthcare, but these are often done in silos, and we still lack a broad framework that brings in every healthcare participant. And as a result of sort of the explosion in digital transformation that we've experienced in healthcare throughout the last 30 plus years, this lack of a strategy and actually the adoption of one particular policy barrier that I'll talk to in a second has really impeded progress and put us in the situation that we now face. Over the last 2.5 decades, we have had to contend with the much maligned, much hated and vilified Section 510 of the Labor, Health and Human Services Appropriation Legislation. This policy rider was first inserted in the fiscal year 1999 Labor HHS funding bill by former Representative and presidential candidate Ron Paul. And in it, Section 510 prohibits any funds to be used for the promulgation or adoption of standards for an individual unique health identifier. And this was originally called for in HIPAA that passed in 1996. And so, while the prohibition itself banned simply the adoption of UPI, a long-standing narrow interpretation of this language by officials at HHS effectively created a firewall between public and private sector regarding patient matching generally, and resulted in this failure to develop and implement a nationwide strategy. All that our group, every member of the coalition, had been asking for was to allow HHS to work with the private sector to identify solutions that were cost-effective, scalable, secure, protected patient privacy, and whether or not that actually included the use of a UPI. I think while arguments could have been made for Section 510 in a more paper-based record system before the full implementation of HIPAA, not only is it no longer necessary, but it's done far more harm than any perceived good. Our modern healthcare system that relies on electronic health records enables interoperability, and is increasingly incorporating new tools such as artificial intelligence, requires a broad strategy to improve patient identification and matching. And that is exactly what we are trying to accomplish. Next slide, please. So what have we done about it? Well, after sort of informally and individually working to try to address these challenges for many years, the Patient ID Now Coalition, in large part thanks to Kate and the AHIMA folks, was formally founded in 2020 with several leading healthcare organizations, including AHIMA, CHIME, HIMSS, and Intermountain Healthcare, all committing to advance through either legislation or regulations a nationwide strategy to address patient identification and move Section 510. Our coalition currently has over 50 leading healthcare organizations representing patients, providers, the health IT sector, and public health, who all support the mission and vision of the coalition. And all of that information can be found on the website, which I believe is in the chat. Next slide, please. So after, primarily focusing on removing this UPI ban, which we did see some progress before it ultimately succumbed to the political realities around removing legacy appropriations riders, in 2023, the coalition started a sort of a two-track strategy that focused on both removing the ban as well as using a legislative strategy to improve patient matching without touching the sort of lightning rod that is the UPI. So this sort of second tack included looking at other opportunities to make progress, such as leveraging subsequent cures, 21st century cures follow-up work like Cures 2.0, trying to support additional HHS dedicated funding for patient matching activities, and eventually drafting legislation, the Match It Act. Next slide, please. So recent progress to date. Despite the lack of a total victory, we have been very active and we have made a lot of progress on Capitol Hill. We've continued pushing every year for the removal of Section 510, engaging congressional leaders, appropriators, and members of Congress, as well as external groups. For fiscal year 2025, we had 150 organizations sign on to our 510 repeal letter, which is the most to date in the 5+ years that we've been doing this. The coalition has also worked to secure dedicated funding to support ONC's patient matching work. And as Kate will get to in a minute, we saw both the development, creation, and eventual introduction of the bipartisan Match It Act in both the 118th Congress last year and the 119th Congress this year, and we're just getting started. With that, I believe I'm turning it back over to Kate.
Great, thank you, David. So as David mentioned, the Match It Act was originally introduced in 2024 during the 118th Congress and was reintroduced this spring into the 119th Congress. I know Katerina is posting a lot of links in the chat as we go through this that will help be references to the things that we're talking about. But right now, I'd like to review the bill and what it would do within industry and government. And then I'll turn it to Cassie Ballard of CHIME, who will explain how you on this webinar can engage to support the bill. But first, the Match It Act is, as David mentioned, a bill that was developed to address patient matching without touching a unique patient identifier. So it does 4 basic things throughout the bill. The first is that it would define the term patient match rate. So right now, we know that throughout industry and government, there is no one sort of definition of how a patient match rate is measured. Different health systems, hospitals, clinics, payers measure it differently. So this legislation would instruct the U.S. Department of Health and Human Services to work with stakeholders to define and standardize how patient match rate is measured, to improve accounting and duplicate records, overlaid records, instances of multiple matches found, and mismatch rates within a healthcare organization. So it would allow tracking of patient match rates across organizations and foster sort of that process improvement across the industry over time. The second thing it would do is to establish an industry standard data set to improve patient matching. So it would instruct the Assistant Secretary for Technology Policy / the Office of the National Coordinator for Health IT, as it was formerly known, to work with stakeholders to define and adopt a minimum data set needed to reach a 99.9% match rate. So that does not actually instruct anyone to reach a 99.9% match rate. What it does instead is instructs ASTP to say, if it were theoretically possible to get to a 99.9% match rate, what is the list of demographic elements that needs to be included in an electronic health record? And then once that list is created, it would be instructed to create, update, or adopt data standards to ensure demographic elements are entered into a standardized format. So once that list of demographic elements has been made available in an EHR, the way that they are entered would be standardized to help with the interoperability and matching those demographic data across systems. Next slide. The third thing it would do would be to incorporate those demographic standards into USCDI and then roll that up into the Health IT certification program. So this would basically mean that all of those standards would be available within any certified health IT. And then finally, it would give us sort of a way to begin to measure where we are with patient matching. So it would require CMS to include a voluntary attestation within the Promoting Interoperability program for eligible providers to meet an accurate match rate of 90% based on that definition from point number 1. So it would be a bonus measure, and no attestation would not negatively affect the total score. But really what it would say is, are you at 90% match rate? Yes or no? For those that answer the question, they would get a bonus. So it's sort of a carrot approach to help begin measure where we are with those patient match rates. And then finally, ASTP would be directed to coordinate with other federal partners to set up an anonymous voluntary reporting program for providers to submit that matching accuracy data to HHS. So again, we did not want to increase burden on providers. We want to make this so that it actually, helps people figure out where they are. So giving incentives or making the reporting programs anonymous and voluntary are ways to help us sort of begin to figure out where we are without increasing that burden. Next slide. So I know that was a lot to go through, but in a very simple way. Number 1, the bill would define the term patient match rate. It would create a minimum demographic data set to be included in Health IT and standardize the way those demographic elements are entered. It would incorporate the data set from number 2 into certified health IT products. And then it would provide mechanisms to begin to measure where patient match rates are within the healthcare ecosystem. Next slide. As you can see, we have 11 co-sponsors on the organization so far this year. It is bipartisan and was introduced by Representatives Mike Kelly and Bill Foster, our longtime supporters of this issue. But we are always working to increase the number of co-sponsors to make it so that this bill has a greater chance to pass. So I'm going to turn it now to Cassie to talk a little bit about how you can help support this bill.
Thanks, Kate. So this bill is supported by over 25 organizations, including health systems, associations, and more. And we are working to increase this the number of endorsers and hope to get some of your organizations on after this webinar. Can you go to the next slide, Katarina? Thanks. So how do endorsements help? I think endorsements help in a couple ways. So they show members of Congress who may be interested in co-sponsoring the bill that their support in their district or in their state. So that's one way they help. I would also say they raise the bill's visibility, but also credibility, because it shows that trusted organizations support it. And as a result, it's taken more seriously. This is helpful given the fact that there are thousands of bills introduced each Congress. So, making it more credible is helpful. And then I would just say that it also shows that the bill is gaining momentum with the more organizations that endorse. Next slide. So how can your organization endorse? This is sort of our call to action. So a lot of times it's up to a member of your leadership team. That may be a CIO or CTO or another C-suite level person. Or if you have a GR team, that would really be the place to go to. And so when you're having that conversation, I think it's helpful to give examples of why you think the Match It Act could help patient ID issues at your organization. And then, of course, we have a one-pager, so make sure to share that as well with whomever you are speaking with. And then I would just say that, myself, Kate, or David, any of us would be happy to chat with your boss or the person in your organization that would make this sort of decision and just walk them through the bill personally as well. We'd be happy to do that. And we also included a HEMOS advocacy email address on this slide if you want to follow up with any questions. Next slide. So if you support the bill as an individual, there are two ways that you can let your member of Congress know. There's a Take Action page on the Patient ID Now website. There's also a Take Action page on HEMOS website, and Katarina put that in the chat. So feel free to fill that out now so you don't forget, or at least open the tab and go back to it later. And so that's just a very easy way to participate in our email campaign. I think it probably takes less than a minute to just fill out your information, and then that will go directly to your representatives. Next slide. And this is where we take questions.
Great. Thanks, Cassie. So as was mentioned earlier, Katarina is posting the links that were mentioned earlier in the chat. So please make sure to go to the action centers that are linked there and write your members of Congress and find out more information and see if your organization would be willing to endorse this important legislation. But I know we've got a number of questions in the chat here, so I'm going to start going through those. But for our panelists, there's a couple of questions on the use of AI. So how does that sort of address the patient matching problem? Is that a way that we can start working on this? Are there concerns with that? Would any of the panelists like to answer?
Oh, I guess I could talk about it a little. I mean, I think that the biggest challenge we have right now with using AI in patient matching is that the challenge with it is inherently that the data is already flawed, usually. Like there's a reason that there's an error in the record in your system already, and that there's something in that data that's already not correct. So utilizing, for example, if you utilize a learning technology or an LLM to try to track how you make decisions on possible duplicate records and replicate that, you're going to have a ton of overlays as a result of that, because you could have the same pattern of demographic discrepancy in two different possible duplicate record pairs, and one is the same person and one is not, because you might be looking at maybe the first name is off by 1 or 2 letters, maybe the date of birth is off by 1 digit. If they have a social, maybe it's off by 1 number. So, and in some cases, that's fine. And you would say, yes, these are the same person, but in a scenario with that exact same discrepancy pattern, they're twins and they're not the same person. So it can be really hard to trust a large link, something that's tuned and constantly learning. So if you are working with a learning technology, understanding what it's learning from, what the data set is, how that's altering it as it works through it. I mean, there's a lot of major concerns, which I think is why most of the matching right now is, there's a lot of the referential that's trying to just look at more information so I can get more data in than I have available to me in my health system, and I can match on that. Or, some of the, biometrics have been kind of a slow start for us, but like looking at some of that and how AI can help with that, I think is this potential solution. But right now there is not a great patient matching AI solution that's built.
Yeah,
I would
I would
say.
agree.
Yeah.
The major problem being most LLMs are probabilistic and not, deterministic, and that's a huge problem here. You need the right answer. You can't make a wrong answer. And then the other bigger problem is you can't feed it the protected health information or demographics into the model, because then you're putting that patient's demographics and personal information out into the world for abuse and use. So no right now, but AI could augment some of the other proven technologies like really good matching algorithm software, including referential algorithms, or biometrics, which are about a 1 in 1 million false positive rate. And so I think there's existing technology without the AI, and then the AI might be able to feed that technology on the, kind of afterwards to clean up some of the data.
Absolutely. So there's another question here for our panel. Someone mentions that they have noticed a higher number of contact moves for patients visiting the emergency department.
Yeah.
So is that sort of a similar pattern you see otherwhere? And just to sort of add on to that, for my own question, are there different departments or demographic groups that maybe experience patient matching differently?
Yeah, I'll jump in on that because I did my thesis on this a number of years ago and published that study, and it was used in a Pew Research article and some other things. So my work on that is out there in the public domain. And what I found in my own organization, this was an IRB approved study, was certainly that it was the emergency room, because people are coming in, they're not necessarily expecting to go in, so they don't necessarily even always have their IDs on them. They don't have that kind of thing. You also get a lot of the fraudulent activity coming through the emergency room as far as drug seekers and things like that. So it's very difficult. And of course, we have legislation in place too, which is good. That we have to treat those patients no matter what. So we don't always, and it's a more emergent environment too. So between that and the legislation, we don't always take the time up front to try and figure out who that person is, and then we round back later to try and get their identity. And so a lot of times, just by the nature of it, or for us just being cautious, making sure that we're not breaking any laws, you definitely have this mix that's ripe in the ER for a lot of patient misidentifications. And I think in my study, it was well over 70% of overlays or misidentifications came through the emergency room, for sure.
Great. So another question in the Q&A. Are there any recommendations to help lower those entry errors in the front access? So, are there ways that we can help patients enter their information better, or front desk? Can you talk a little bit about maybe solutions that you have found?
Well, I'm going to jump in again real quick. I think there's two things. First of all, there's scripting and that kind of thing, getting your staff on the right page as far as asking all the same questions and doing their due diligence up front. But also, something we haven't really said is a lot of the organizations that are contracting with third-party vendors, either on the back end or the front end, to try and do matching against public data, have a huge advantage. And there's a lot that aren't doing that, right? So you have some organizations that are spending a considerable amount of money with these third-party vendors to be able to do that kind of thing, and others that aren't. But that can be put onto the front end as well. So when someone comes in and they say, I'm Mike Smith and whatever, it goes out at that point, runs against third-party data, and comes back with a screen for the registrar, or even an automated process if it's the patient doing it themselves, saying, kind of like you've probably seen with other websites where it says, did you ever live at this address? Did you ever, own a whatever kind of car, or have a mortgage with this person, or whatever? And that kind of information can come back on the front end to verify that that is the proper Mike Smith. So I think some of those hold promise to be able to weave that into the front end, not just using that on the back end to verify patients. That's one thing that I've seen.
And I'll just add, I think some of it, if you're, just talking about standards on how data is entered, and there's been, AHIMA's done a lot of work on this recently. There's a AHIMA naming conventions framework that talks about how to put data into the EMPI so that we're all kind of entering things the same way. There's also the was it Patient USA, that dealt with the address and how to put address information in. So I think like some of that is just making sure we're all putting data in the same way and trying to, work together across organizations that we're kind of all entering things in the same manner would help with that kind of cross-system matching.
I would echo the points. I think data standardization and interoperability is huge. I think the better patient matching algorithms, including referential database, like not just within your EHR, but looking outside, looking at tax records and death records and Department of Motor Vehicle records and all sorts of third-party triangulation of the data, it becomes very obvious. You take many out of the maybe or the no bucket and put it into the yes or the no bucket, right? Because, Kate McFadden, who had a different name 3 years ago, and then there's a marriage license on that stating both names, it becomes very clear that that's actually the right person. Or if I changed my name 3 years ago, then it becomes much easier to figure that out from the patient matching algorithms and software. And then again, biometrics, they have their advantages and disadvantages, don't work for everybody in edge cases or extremes of age. But if you make an opt-in where people can use it if they want for the betterment, then you could eliminate that. I mean, no matter how good your scripting ever gets for human beings, we still make errors about 10% of the time, even in some of the best scenarios. And while I love the Match It IT bill, we're looking for a 90% match rate. If I got my diagnoses of you when you walked into the ER right 90% of the time, or if our banks got your money to the right account 90% of the time, we'd be out of business, right? So I think we need 99.999% correct matching rates. That's what we should be shooting for. And I'm in agreement with the bill. I'm in agreement with the direction it's going in. But in my own hospital, for my own patients, we're going to do better. And I think we need proven technology that can do that to get us there.
Great. As we go on to the last questions, I'm going to ask Katerina to go to the next slide with contact information. There's a few questions about how to contact us. So feel free to reach out to us if you have any questions about this issue or the coalition. There is a question on how to join the coalition. So if your organization, we take organizational memberships. So if your organization would like to join the coalition, feel free to reach out to any one of us on here or advocacy@ahima.org, and we're happy to talk you through that. There's also a webinar survey posted in the chat. If you would take that before you leave, and that will also be included in the email that's sent out with the recording and the slides. But one sort of last question in the 2 minutes we have left. There is a lot of questions in the Q&A around privacy. So how does privacy sort of interact with patient matching?
I mean, anything needs to be privacy by design. And again, in healthcare, this is no different than HIPAA and everything else. We need to keep our patients' information private, but we also have to deliver quality and safe care. And not knowing information about a patient is many times more dangerous to that patient from a healthcare perspective than keeping that patient's privacy and compliance intact is no good if the patient dies. So I think that it's a balancing act, but I think that any good system or technology or process needs to have privacy front and center and protect it at its utmost. But I think that's possible in this day and age.
Mm-hmm. Like it's difficult right now at this juncture, not just with healthcare, but with a lot of these things, like we were talking about the clear for getting on planes and things like that, where you kind of go, well, we're at this point where what is safer? I mean, is it safer to not sign up for these programs and have things like matching identifier assigned to you, or is it safer too, right? Like if you're letting an algorithm do all the work, is that better? I mean, don't you sometimes get ads that would probably be a little more suited to your wife, or your wife gets ads that are more suited to you because they were the last one using the computer? That's because they're using AI and they're using these algorithms to try and put people together. And, if we go ahead and sign up for programs like, we do it with travel, like a lot of people have no problem doing that. Well, this is your healthcare, right? So we're at a juncture where you can sign up and say, I want to do this, or, if we move towards a national patient identifier at some point, knowing the challenges of that, I think the Match It initiative is the next best thing that we need to be doing towards this. But I think that's something we have to think about. Like, at what point is it safer for us to go ahead and enroll in some of these things and agree to them, as opposed to, shunning them and saying, no, I don't want any of that. Because if you don't, then you're going to have algorithms trying to do it either way. And I think that's a difficult thing. I mean, I'm just as concerned about our privacy in all areas of our life with technology as anybody. I can be a little even conspiracy theorist, I'll be honest, about that, right? But I think it's at a tipping point understanding some of this technology as I do now, where you kind of say, honestly, the safer bet is probably to go ahead and do it the right way, as opposed to letting algorithms try and figure out who's who. And I think that's kind of how that's one of the privacy things I see these days.
Absolutely. Rachel, any final thoughts on privacy?
I mean, I think you guys both made great points, Sean and Grant, and it is a challenge, and we're all forced with and I do think younger generations have less concern about privacy than older generations too. So some of this is a generational thing. Like, younger people are putting all of their health information on their social media, and they're totally fine with that. So it might be something that we see slide as we go. But I saw some comments in there about, like, why hasn't this happened yet? What's going on? Why do privacy? There's people in Congress that, like, this is a non-starter for them. They feel like this is Big Brother. They feel like it's a problem, and that's why I think it's really important that Patient ID Now did pivot to this other policy, because this has more focus, I think, on patient privacy, and it's more digestible for people when it comes to privacy than necessarily the unique patient identifier is. And kind of that's, I think, how we got here. And I think it's a positive pivot.
Well, I want to thank all of our speakers today for joining us. Thank you to all of our attendees. Again, please feel free to reach out if you have any questions, and we will be sending out the recording and information later this week. Thank you all.